Now we're getting a view from possibly the top of the mountain, a view from ATAGI. Katie Flanagan is an ID physician from Launceston.
Great, well thanks to the organisers for inviting me to come and talk today and give you a view from ATAGI. I won't necessarily tell you exactly what our new recommendations are going to be because I'm not allowed to, but I'm just going to really run you through many of the deliberations that we've had. So declarations, obviously I'm a member of ATAGI, otherwise I wouldn't be giving this viewpoint, and I've co-chaired the ATAGI COVID-19 vaccine working group, also previous advisory boards, but not for some years now. I'm the president of ACID, and these are my views, not necessarily those of ATAGI or ACID. So the ATAGI structure, for those of you that don't know, we have 15 voting members and 7 ex officio members representing all of those organisations you can see there. And primarily our role is to provide technical advice to the Minister for Health and also to produce the National Immunisation Handbook. But also we do give advice to research organisations, advise PBAC, National Immunisation Committee, and CDNA and ACV. So there's a lot of collaboration that goes on, and all of this is supported by the National Centre for Immunisation Research and Surveillance, who come to our meetings, put a lot of the documents together, a lot of the talks together, and give us incredible support. So the COVID vaccine program in Australia. So this really would be the most complex immunisation program ever developed and delivered in Australian history, as you can imagine, with the time frame and the fact that eventually we were looking to roll out to the entire population. And some different processes had to be developed to actually set up a program in a pandemic setting. So you can see on the right-hand side of the table that there were some different processes. The SITAG did a lot of the Australian government advice and made decisions around purchasing of the vaccines, which was a little different. And the COVID vaccine task force, rather than the immunisation branch, were the ones that actually worked with the jurisdictions for program implementation. And as you know, some of the implementation was done by the federal government, particularly in the aged care facilities, rather than by the local immunisation committees. So to manage the workload, some different structures needed to be in place because traditionally ATAGI would meet every few months and we would be discussing policy, but to actually develop the policy this quickly, we needed some new processes. So at the time, 3 expert working groups were set up as the vaccines were, phase 3 trials were coming out and vaccines were getting to the point of being licensed. So there was a prioritisation group, which I led, an implementation group led by Robin Gibbs, and safety and confidence group led by Nigel Crawford, who's here today. And then from January onwards, when Nigel Crawford took over as chair of ATAGI and Michelle Giles as the co-chair, we changed that to the whole of ATAGI coming back and giving advice and doing the advice around COVID and meeting every week. That's the ATAGI COVID-19 working group, which is still ongoing. Initially, we were meeting weekly. More recently, we've met fortnightly. And there is also an ongoing safety group led by Tony Corman, and they initially met fortnightly, and I'm not sure how often they're meeting at the moment, but certainly not as often as that. Technical support, as always, provided by NCERS, and all the way through this, the ATAGI COVID executive has met to oversee what's happening, and so the task force members, government members, and the co-chairs and leads of some of these committees. So right at the beginning, we were thinking of our prioritisation. What were we actually trying to aim to do at the very beginning? And obviously we had a number of constraints, particularly around vaccine supply. And also just in terms of what the public health response was going to be and what the aims were. Was it a suppression/elimination approach? Were we going to allow other waves to come through? So these were considerations at the time. But essentially, we really felt that reducing serious illness and death was the main aim of the programme, but if possible to reduce disease transmission. And at the time we didn't know whether the vaccines would work against disease transmission. And as we know, the evidence was emerging rapidly around the fact that you could also transmit the disease before you even had symptoms. And initially, we didn't know that either. So we were working with a lot of unknowns. But there were other aims around equity, promoting trust, eventually to set up a national immunisation programme for COVID-19. And we wanted to keep the country running and maintaining essential services, so thinking about those people as priority populations. And of course, we had many unknowns at this point in time. We didn't know what would actually happen in a real-world setting, sort of outside clinical trials, which were done in generally healthy adults. Multiple priority populations were missed, and we still lack those data in those priority populations, particularly the severely old and frail, which were again omitted from all the early trials, and we had to just make some recommendations with that uncertainty. Immunocompromised people, people with severe disability, and pregnant women, which is one of my bugbears, that they just get excluded from all of these trials, and we don't have the data, and yet they end up being a priority population. We did also say at the beginning that we thought that the vaccination should be strongly encouraged and not necessarily mandated, and as we know, that didn't play out quite that way for one reason and another. I'm glad that now perhaps we've moved away from those mandates again, because I don't think that necessarily helps with vaccine acceptance. So in terms of the work that we did, we met often weekly or twice a week or 3 times a week. It was a lot of work and a lot of time, and we went through multiple iterations of the clinical guidance. So version 1 came out as soon as the Pfizer mRNA vaccine was approved. But every single time there was a new TGA decision on a new age group, a booster or an adverse event signal, then of course we had to update the clinical guidance. That is now, I'm not even sure what version we're on. I don't think we've actually put the version because there have been so many updates to those. But they will soon be incorporated into the Australian Immunisation Handbook as a chapter, but more as a living guideline, not quite to the extent that every week there would be an update and a review of papers coming through, but there will be an update, and initially that will bypass the normal quite lengthy NHMRC approval process for chapter updates to the handbook. A lot of documents, of course, had to be developed, and every time there was an update, every consent form had to change, information sheets had to change. There was a lot of work developing tools around decision guides, pregnancy, immunocompromised people, etc., and a lot of liaison with specialist societies. We also liaised with a lot of our NITAGs internationally and had meetings to understand their recommendations and their decisions around why they made those recommendations. And we frequently met with the CMO. Some of the executive would meet with the CMO to discuss ongoing deliberations. Alan has already shown this slide, and I'm not going to go through what the current recommendations are because I think most people are familiar. We've got first boosters, and in some age groups, second boosters either recommended or are available for those age groups. And younger children, of course, we're not recommending boosters at present. But I just want to run you through what our considerations are at the moment and what we need to be thinking about for future programming. And there's been a lot of great discussion already at this meeting to give you a lot of background, really, as to what we might be thinking. And we've had some suggestions today of maybe an annual booster and twice a year for people who are immunocompromised. That sounds like a reasonable suggestion. And I think once we get into some understanding of stable COVID transmission, then we might be able to think about whether we get to the stage of just an annual booster. But at the moment, we're not necessarily quite at that stage. So just to remind you, and I think everybody's very aware of this, we have a very highly vaccinated population, particularly in those older people, but very few people who are vaccinated, very few unvaccinated over the age of 16 years. So most people have received at least 1 or 2 doses, mostly 2, but then many have had their boosters and many have had their second booster as well. But I think we need to remember we have that very vaccinated population, But it is now more than 6 months since many people have had their last dose, and in some cases it's considerably more than that. And as we know, in Australia, the current wave is now abating, and this is just very recent data showing the daily cases and the daily deaths. And you can see that they're greatly declined now, and that this current wave looks to be over. The other thing just to point out, of course, is that over time, the death rate is going down with each wave. And so this is global data for different countries, different regions of the world. And you can see that the mortality rates are declining. And that's likely a combination of the viral adaptation, of the immunity that people have developed both through vaccination and infection. So we have a highly vaccinated population. We also know that very high numbers of people have been infected. So national sero surveys that have been done up to the end of August this year show that around 65% of the population have had an infection, and up to 90% of children. So very, very high rates of prior infection now in children. We do know that immunity wanes, and we've seen some good data from other speakers at the meeting to show the waning of immunity. So vaccine-induced immunity wanes, as shown on that figure on the left-hand side here, particularly to Omicron, and we've already seen that figure. However, as we all know, the actual waning of immunity against severe infection and death is a lot slower, both from infection and from vaccination. And so we would anticipate that you should have reasonable protection against severe disease and death for at least 12 months and possibly longer. But it's not up at that 95%. We're talking sort of more around 80% range. And as Alan mentioned, the incremental benefit of boosters is decreasing over time, but we know that boosters do help. So there's been some talk about hybrid immunity. This is obviously the immunity obtained for a combination of vaccination and one or more infections. And we know from all the data that are emerging that hybrid immunity is superior to infection alone or vaccination alone. In the Australian context, we have people that did not have the original infections and mostly were fully vaccinated and then had Omicron infection. So this is a different scenario to many other parts of the world. But yesterday there was a mention of original antigenic sin, of immune imprinting, and obviously that has been a concern, which is where what you see initially is then what is boosted over time when you see subsequent variants rather than the variant-specific immunity. And that certainly does seem to be an issue. Immune imprinting does occur, but you can boost immunity to the Omicron variants when you give an Omicron vaccine, and likewise when you have an Omicron infection. So you definitely get a predominance of what you've seen before in terms of your breadth of antibody responses, but you are actually able to get de novo responses from naive B cells as well. And that would stand for the T cell immunity as well. So hybrid immunity, of course, is affected by a number of things. Which vaccines have been used, the timing of those vaccines, how many doses you've had, and then what variants you might have been exposed to and had an infection from, how severe that infection is, all your susceptibility factors. And really what this leads us to at the moment is that everybody's immune experience is incredibly different now in terms of all of those different factors, and it's very hard to predict at an individual level what impact vaccination would have. And the reason I've shown the figure on the other side is from this lovely paper from Science where they looked at all these different types of people. And all I want to draw your attention to is the bottom line. You've got all the people in all the different colours. And those people have all had a completely different immune experience. You've got the infection-naive ones in blue. You've got those infected with Wuhan original strain, those with Alpha, those with Delta, then those with Omicron, those infected after being vaccinated, those infected before being vaccinated. And this study just did some really nice immunology showing how that could actually impact your immune status to Omicron, and in fact suggested if you had Wuhan strain early on that would actually completely ablate your response to Omicron. That doesn't apply to Australia, and I don't think that really other studies are replicating those findings. But I just think it's really interesting to consider how we're all going to be sitting in a completely different place in terms of our immunity. So we've got a highly vaccinated population that was predominantly COVID naive when vaccinated, then have had predominantly Omicron infections, not entirely. So we've already now laid down our immune memory from what we've got already. And I think the fact that we vaccinated our population first before being infected probably is beneficial to us. But in adults, if they've had more than 2 doses plus an infection, they're likely to have good sustained immunity against severe disease and death, particularly if they've got good immune systems and they're not so old. And Omicron protection, though, as I said, is enhanced by subsequent boosters. So there will be some enhancement of protection, albeit not what we were seeing at the beginning of the vaccination program. I think for children under the age of 15, if you're fully vaccinated and prior infected, and we know many of those children are prior infected, then I think they would have extremely good protection against any severe outcome, which they weren't even susceptible to in the first place particularly, and may well be even better protected than boosted adults. So there's possibly little added benefit to further boosters for them. So now just getting onto the bivalent vaccines compared to the ancestral vaccines. This is something that's come up in the conversation today. Now, obviously, at the moment, we've got approvals for both the Pfizer and the Moderna BA1 plus ancestral vaccine, and we have ATAGI recommendations for both of those that they can be given to those over 18. The Pfizer bivalent BA45 has just been approved by the TGA for those over the age of 12, and ATAGI advice will be coming shortly on that. And the Moderna bivalent vaccine is under consideration, under evaluation by the TGA at the moment. So the current ATAGI advice is that there's no preference for ancestral versus bivalent, and that we don't recommend bivalent for primary vaccination. There's absolutely no data for that at the moment. And of course, those that haven't been vaccinated probably aren't going to be at this stage anyway. But there is evidence that the 4-5 variant does induce superior neutralizing antibodies to that variant and some of the newer subvariants, and similar or slightly higher ancestral strain neutralizing antibodies as well. The safety profiles look fairly similar. In terms of clinical benefits, there are now emerging data that there is a superior clinical benefit, although how that really is going to translate, time will tell. And I don't think that the data are strong enough to say that they are, that the 4-5 is superior to ancestral or the bivalent necessarily at the moment in terms of clinical benefit. But a huge study from Denmark in millions of people does suggest there is a benefit, and that actually the 4-5 is the most superior at the moment. The other thing just to bear in mind, of course, is mRNA ancestral vaccines are being phased out globally. So eventually, I think only the bivalents are going to be available. Just looking at some of the other technical advisory group recommendations around the world, I'm not going to expect you to read this, but you can see we've got recommendations from JCVI, ACIP, NACI, Europe, STIKO in Germany, and the WHO recommendations. And I thought I'd just point out a couple of things from some of these recommendations. And ATAGI has looked at the recommendations across all of the world. Of course, they have got a different seasonality to us, so they've made additional booster recommendations going into their winter. In terms of preference around whether we use the bivalent or the ancestral, JCVI have no preference, but you'll see that nearly everybody else does have a preference. In the USA, the monovalents are not even available, and they are strictly sticking to the BA4-5 variants. Canada prefers bivalents, as does Germany. But WHO SAGE would say that there's insufficient data at the moment for a preferential recommendation. So these are all things that we've been thinking about. And then in terms of boosters, so the JCVI recommended an autumn booster, did not mention what role previous boosters would have. USA as well, booster doses, and regardless of the number of previous doses. Canada also a bivalent booster regardless of the number of previous doses, whereas Germany is very much focused on immunocompromised and very old people, and WHO SAGE would be recommending a very targeted approach for additional boosters. So different countries with slightly different approaches. And I think one thing just to point out there and think about is maybe it's time we forget about how many vaccines you've had now and how many boosters you've had in the past and just focus on, is a booster going to be available to people who would like it and those who are considered at risk? So obviously we don't know the future and exactly what's going to happen, but the current vaccines I think are likely to provide reasonable protection against future variants that don't even exist. And we did hear that yesterday, that people are having immunity and antibodies that can actually protect against vaccines that don't, against variants that haven't arisen yet. And protection from severe disease and death has always been encouraging in this programme. And the more closely related the variant to which an individual's been exposed, or the more recent that exposure has occurred, then the better the protection. Boosters definitely work, but the incremental benefit is declining, and we know that the actual protection is rapidly waning, and certainly against infection itself, clinical infection, it's not fantastic, it just really does help against the severe disease and death. But intermittent boosters are clearly likely to be required in the future, and let's hope that eventually, yes, we can settle down to an annual pattern of boosters. We don't really want to be in the process of chasing waves as they emerge, and really the more vulnerable people will have to be a focus. I think variant vaccines, we don't want to be on a constant roundabout of trying to keep chasing variants, as Cantor was explaining yesterday, and I don't think it's necessarily necessary, and certainly not a very practical approach going forward. And of course, we've heard a bit now about the vaccines that are coming forward. There's a huge vaccine pipeline coming through. Some of those are trying to overcome the immune imprinting effects with being more epitope specific, focusing on conserved regions, and of course there's the approach with mucosal vaccines to try and prevent disease transmission and induce mucosal immunity. So I'll finish on this slide. It's been a roller coaster road for ATAGI these last few years. I think it is finally slowing down, and we should be coming through with some ATAGI advice in the not too distant future. Thank you.
Katie, thank you. You've got some nice people on the roller coaster with you.
I know.
Presumably there's been a lot of bonding and getting to know people's working style. And
well, I was just saying to some of the people here how they became my very close friends over this with the number of meetings. Cantor, for example, was on my prioritisation committee, and we got to know each other very well without actually meeting.
So there's an advantage. There's a question from table.
Ken Griffin from the Australian Primary Healthcare Nurses Association. Thanks for your work during the place. You've done a great job of making it look like a linear process, but I'm sure it's very messy. So my question is really one of process improvement, given the experience for ATAGI. Are you going to go through a process of looking at how you would better position yourself or avoid some of the things that really probably cropped up for the first time for your group during this time?
Yeah, thanks for that question. Look, there's been a huge number of learnings, of course, over this process, and I think people perhaps wouldn't realise a lot of the work that was going on in the background, and when the press and lots of people were advocating for certain groups and certain things, all those discussions were happening. But they have, you have to go through a process of being sure that you're making the right decision and you're giving the right advice. Alongside that, there were conversations that we were having with NACI and JCVI, regularly meeting with them in the early hours of the morning to have some of the discussions. So I think our processes, perhaps to the outside, may not have looked quite as smooth and good as what was actually happening on the inside. But yes, of course, we've learnt a lot, and we are looking at streamlining and seeing where we're going forward anyway. And I think that the process had to be changed anyway at the beginning of 2022, having had those 3 groups and all the active work that needed to be done. And we needed to pull ATAGI back into being the group that did all the work rather than a lot of other external experts. But yes, it's an ongoing learning.
And Ken, thanks for saying thank you, because there are a lot of people in this room on different committees who have put an enormous amount of work, and there haven't been enough thank yous in my mind, from basic research through to modelers, epidemiologists and so on.
Yeah, and it was a massive team effort. I mean, my part was very peripheral compared to all the amazing people that were involved in this.
There's a second question from the middle table.
Yeah, Peter Richmond, and just acknowledging the fantastic work that everyone did. I just cannot imagine it. I did share an office with Chris Blythe, so I have some idea of the duration of some of those teleconferences. My question, I guess, is also probably relevant to the people in the room, is healthcare workers. And, what should we be doing as people who are committed to vaccination? And, do we need to be thinking about seasonal vaccination, or when there's a wave, should we really be saying, okay, I better boost my immunity for a few months? So I just wondered whether you had any thoughts about that in terms of how we should be sort of setting an example, I guess, for people working in healthcare institutions.
Yeah, that's another good question, and certainly you've seen that some of the NITAGs are still focusing on healthcare workers as a priority population. I think when we realised that the vaccine didn't prevent transmission very well, and at the moment not at all, that perhaps if the healthcare worker is a healthy person that doesn't fall into a high-risk group either by age, immunocompromise or other factors, that they'd be using PPE at work anyway, and is it really that beneficial? But what we did do with the ATAGI advice with the second boosters was have that permissive recommendation that people could take up the vaccine if they wanted to and have an extra dose, and that was partly aimed at concerned healthcare workers and those that felt they really needed to do that to give themselves that extra protection, because as we all know, there's been a lot of healthcare workers' distress and concern and anxiety around COVID risk. So I think we've left it to personal choice, really, whether people do, and I think everybody's circumstances, again, are different. When you've had your last infection or if you've had several, and like, for example, for me, I waited for my fourth dose just not long before I decided to travel internationally for the first time to use it in that context, but I think everybody does it in a slightly different way.
John?
Given Shamez Lahani's talk yesterday about kids, and increasingly countries are moving away from vaccinating children, and that we've got a high infection rate and we recognise they get protection and they have low rates of severe disease, what's ATAGI's current thoughts on what we should be doing? Because vaccination is languishing at about 40%. Should we be promoting it? Is there going to be some new guidance about what we do in children, and particularly in those 5 to 15-year age group, not the under 5?
Yeah, so I was alluding to exactly that point, basically, with my own personal viewpoints on that. I don't think I'm allowed to tell you exactly what ATAGI are going to recommend, but we've absolutely taken that on board. And as I showed, we've got really high rates of infection in that age group, and many have had 1 or 2 vaccines in that slightly younger cohort. So, and there's also the risk, which is not insignificant, of myocarditis, pericarditis in the younger males. It's still rare, but it's certainly there. And I'm sure many of you have also dealt with the huge number of people with cardiac issues with no evidence of myocarditis and pericarditis, but ongoing chest pain and palpitations. I've seen loads in my vaccine clinic. So all of that's been taken into account, and the next tranche of advice won't be too far away.
Katie will be watching this space with interest. Thank you. Terrific presentation. One more question from Rod.
As you said, thank you for your work. A lot of people here have been on ATAGI. ATAGI started in 1998, and those that sat on it are frustrated by good advice being sabotaged by implementation process. You advise the minister, and those on the ground are frustrated between the gap between what you do. Any suggestions? Because the Immunisation Coalition is scratching its head and going grey every day between your advice and the implementation.
Yeah, there definitely have been implementation issues, and I think some of the early decisions around how it was going to be rolled out and not necessarily involving all the JICs didn't work terribly well. They were the ones with the sort of jurisdictional skills, I think, to get moving with things. Again, I think it's been a learning process as we've gone along. We have only been able to advise and provide implementation materials and get advice out in terms of who we think should be vaccinated, and we know that there are many populations that were where there was inequity with that, with the Aboriginal Torres Strait Islander populations in some situations, but also the culturally and linguistically diverse population, and people in areas with poorer health literacy. And I think that is still areas where we need to work more. It's not really ATAGI work, as you know, but I think getting the messages out to those people and getting into those communities and making sure they're vaccinated is really important. So yeah, look, I think there's more work to be done from that point of view. I think the government have taken on a lot of those lessons, or some of those lessons. I'd like to think so. Some of the people that we're working with in departments seem very aware, and let's see if there'll be improvements.
Fingers crossed. Katie, thank you.
Thank you.
Many